Well, people are still coming in, but we're a couple minutes past and we owe it to the people who are here to get started. Good morning, everyone. I'm Claire Olivers. I'm the president of the Retired Public Employees Council of Washington. And I want to welcome everybody, especially some new members who have recently joined Retired Public Employees Council. We're thrilled you're joining us for today's educational program. We also extend a special welcome to those who are joining us today from among our labor family and from partner retiree organizations. Welcome. For those who are new to Retired Public Employees Council, you have joined the premier public sector retiree advocacy organization in the state with more than a 50-year history and 13,000 members strong. RPEC is affiliated with American Federation of State, County, and Municipal Employees. We are Chapter 10 of the AFSCME retirees. Before we begin, I want to recognize Derek Van Spoor, Associate Director, and Alyssa Brady, Project Coordinator from the Council Office, who will be facilitating the Q&A portion of today's program, and of course, hosting the Zoom. Today's presentation is entitled Insights on Universal Health Care. For many years, RPEC's legislative priorities have included advocating for universal health care. The legislative priorities is our guiding document that is developed by our members and refined and voted on by the delegates at RPEC's biennial convention. We have a very active healthcare work group that monitors the meetings of the Universal Health Care Commission. We know that the commission has been studying the viability of universal health care and has made important strides. We'll hear about them today. As I mentioned, RPEC is union affiliated. The national labor community under the leadership of Roach has been instrumental in elevating the importance of our country moving toward a universal health care system, also known as a single payer system. She has valuable insights to share. Our presenters today include Ross Valore. Ross is the board and commission director at the Washington State Health Care Authority. Ross has a law degree and was previously the executive director of the Certificate of Need program at the Department of Health. He's well versed in open public meetings and the current healthcare system. Mary Franzen is the coverage strategies manager at the Washington State Health Care Authority. She leads the team that staffs the Universal Health Care Commission. Her previous policy work includes Medicare and Medicaid demonstration projects that explored care delivery models and improved health outcomes. Roach is the national coordinator of the Labor Campaign for Single Payer. She's the former executive director of the Minnesota Nurses Association and has worked in the labor movement for 34 years. Rose has spent more than 2 decades working in the healthcare justice movement. Excuse me. In terms of some quick housekeeping, all attendees will be muted during the presentation. The Q&A portion of the program will begin after the presenters conclude their presentations. Matt Grishong, chair of RPEC's healthcare work group, will kick off the Q&A portion of the meeting with questions developed by work group members. The healthcare work group was established a few years ago to monitor the state and federal healthcare landscape and to make policy recommendations to RPEC's legislative committee. The work group is composed of members from across the state who've been appointed by our executive board. Once the work group's questions have been addressed, we'll entertain questions in chat. We will also try to scan for hands raised using the feature in Zoom, not a physical hand raise, but the hand raise button at the bottom of your screen, the reactions button. And please remain muted throughout the presentation. So Ross and Mary, please take it away.
Thank you all. Good morning. My name is Ross Valore. I am the Cost Board and Commissions Director at HCA. I'm very pleased to be here this morning with you all, especially with folks that, retired public employees, close to what we're doing here today. So Thank you for allowing us to be here. Just a quick introduction to myself. I believe it was mentioned, started off in private practice here in Washington, and then spent about 4 years at the Office of the Insurance Commissioner as a staff attorney, and then went over to the Department of Health as a staff attorney and worked in their policy shop before leading their Certificate of Need program. And I have been at the Healthcare Authority as board and commissions director for, this is finishing up my 11th week. So relatively new to the position, but really enjoying this process of working to prepare the state for a universal system. And excited to talk to you folks about that today. And before I hop into the first slide, we'll let Mary introduce herself as well.
Good morning, everybody. And first of all, am I sharing correctly? Can folks see the title slide?
Yes.
Fine.
Okay, we're good to go. Okay, so I'm Mary Franzen. My title is Covered Strategies Manager. I lead the team that staffs the commission. I have a master's in public health in health policy and management. I mid-career MPH, pivot some years ago after starting out in marketing and public relations for a lot of health-related clients. I was on the implementation side of a lot of demonstration projects, federally funded things, Medicare and Medicaid demonstration projects, got familiar with the delivery system there, and have since sort of backed myself up in the process, working more on the policy end of things and setting policies. So I have to say, working on the Universal Healthcare Commission is really, really fun and interesting. And I've been doing this since last summer, having a really good time. We have great commissioners, and it's just a wonderful idea to try to tackle and figure out. So thank you all for your interest.
Thank you, Mary. And if we can go to the first slide, please. And so the way that we kind of set up this presentation, we'll start by talking about universal healthcare more generally, and then talk about the Universal Commission and some of the work that they're doing. So just to kind of start generally, what do we mean by universal healthcare when we're discussing that in the context of the Universal Healthcare Commission? The Commission's implementing legislation define universal healthcare as a single unified system where all residents have access to healthcare. So that is kind of the definition that we're working off of in the context of the Universal Healthcare Commission. And just a kind of a note regarding what unified systems can look like. I think we traditionally think of single payer, but there are other options in terms of what a unified system can look like. They take different forms, but share some common traits like being organized by country or region, having standardized payment models and rates, and uniform administrative processes. And a really important note, speaking to the different shapes that a universal system can take, is that it can have a combination or a mixture of private and public payers, providers, and care settings. So there's really a lot of opportunity for creativity and suiting the needs of the citizens of a particular state or region to ensure that the healthcare needs are being met under a universal system. And Mary, if you could go to the next slide, please. Thank you. So as I mentioned, most folks' minds usually go to a single payer system when we're talking about a universal. And so that is the first that we'll kind of address here. That's in essence where one entity takes responsibility for financing healthcare for all residents in the context of what we're talking about, all the residents of Washington state. Stated differently, everyone has coverage under one health insurance plan for necessary services. As you would imagine, under a single payer model, there's a lot of administrative simplification by having only one payer. There's also would make reimbursement and other kind of standardized processes a little bit easier because you would only, again, be dealing with that one payer. And we've seen examples of this around the world. Canada, Spain, Taiwan have single payer models where the national government is that one payer. Moving on to a different type of model for a unified system or universal system. is the multi-payer model. Under a multi-payer model, what we're talking about is healthcare being financed by a mixture of public and private payers with the goal of reaching universal healthcare by ensuring everyone has access to healthcare. So that is taking a slightly different interpretation of what universal healthcare means, where in essence, under a multi-payer model, as long as everyone has access to universal coverage, whether it be a private or public option, that would be considered, meeting a multi-payer model. An example of this is Germany, where residents can either purchase insurance from a public or private payers. So those are a couple different options of what unified systems look like. And again, unified systems will typically have a mixture of public and private funding, and usually some aspect of patient cost sharing as well. And when we say cost sharing, we're referring generally to copays, deductibles, premiums, those out-of-pocket costs that patients pay for their care. And Mary, if we perfect.
Yep.
So again, stepping back to take a more high-level view of a unified system and universal healthcare, and thinking about what the goals would be. The central goal of a unified system is to ensure access to high-quality, affordable care for patients without facing financial hardship. And kind of those three key aspects of that goal, which is high quality, affordable, and ensuring that patients aren't facing financial hardship as a result of getting needed medical care. So those are the central goals that kind of inform some of the Universal Commission's work. And as we think about universal healthcare, some other goals include greater ability to control cost growth through standardization, both with rates, reimbursement rates, administrative efficiencies, and a focus on preventative care, which I think under our current system, sometimes we struggle to really encourage patients into the preventative care system. Another goal under a unified system is reducing the administrative burden for providers, again, by standardizing those billing procedures and rates. As we all know, that is a constant source of frustration for our providers, is trying to figure out how to work with both federal and state systems and a variety of payers that all have different reimbursement rates, procedures to get reimbursed, and seeing the really realizing some efficiencies in moving towards a unified system. And finally, decreasing health disparities by ensuring everyone has access to care regardless of financial status, which I think we can all agree would be a great benefit of ensuring that our population's health improves and that everyone has access to needed care. And now we'll move on to discussing generally the Universal Healthcare Commission before we transition to Mary, who will go into some more details. So Mary, if you could move to the next slide. Thank you. So the Universal Commission was created in 2021 and was given 2 directives by the legislature, which this slide nicely kind of parses. The first part of the Commission's directive was identifying transitional solutions to ease costs and access issues related to the current healthcare system in Washington. So that's part of the ongoing work of the board, is to continually be looking for those cost containment mechanisms to ease the cost growth that we're experiencing here in Washington state. The second goal is considering universal system design, which the statute phrases it as preparing the state for a unified healthcare financing system. So that has taken up a large amount of the Commission's work, is contemplating what would be necessary to move towards a unified system, what existing barriers there are to moving to that system, as well as what a design of that system would look like ideally for Washington. And I just want to take a moment to acknowledge that the Commission is able to do this work, which is very technical and complicated because of the amazing Commission members and advisory committee members that we have There is a Finance Technical Advisory Committee, FTAC, as it's commonly referred to, that provides a ton of support and technical expertise to the commission to help us understand the pros and cons of benefit designs, some of the technical legal questions that we're encountering regarding what changes would need to happen on the federal level to be able to move forward with aspects of a universal care system here in Washington. So very much rely on the knowledge, expertise, as well as time and energy of the commission members and the great staff that supports the commission, which includes Mary and two policy analysts. And just real quickly too, I just want to mention, in my role, I oversee the Universal Commission, but I also oversee the Healthcare Cost Transparency Board. And the Healthcare Cost Transparency Board is very much focused on kind of the first aspect of this directive for the Universal Commission, which is monitoring healthcare cost growth and looking at ways, recommendations we can make to the legislature and other actions we can take on a state level to help curb or slow that cost growth. So just as from a state level, HCA level, we're taking a couple different tracks to try and monitor both cost growth now under our current system, as well as, preparing the state for a universal system, which the commission is hard at work on. So just so you have kind of a broad picture of the different ways that we're trying to approach healthcare here in Washington. Mary, if you could go to the next slide, please. Thank you. And we'll quickly here explain kind of the membership and who's part of the commission. The commission is a 15-member body within HCA that includes a broad representation of public and private healthcare experience, including 5 state agencies, members from 5 state agencies, 6 members appointed by the governor, as well as 4 legislators. And you could tell by that makeup, there are a ton of folks with a lot of good experience and perspectives to bring to the table that help us think about these issues, really from a wide variety, both legal, technical, financial. So really have a great mixture of membership. And as I mentioned previously, there is an advisory committee as well that is specifically dedicated to those financial technical questions that provide a great deal of support to the commission. And I also just want to shout out really quickly a couple of our members. Our chair, Vicki Lowe, who wasn't able to be here today with some other work, but Vicki is the chair or the executive director of the American Indian Health Commission and the chair of the Universal Commission, and just does a really excellent job of guiding that work. So just wanted to give a quick shout out to Vicki. And yeah, I think we can move on to the next slide, Mary. And just thinking real quickly about what the commission is trying to do in terms of its input that is getting both from the public and other members of the healthcare community. We stress the importance of routinely and consistently getting input from the public, both through public comment, written comment in between meetings. So very much would love to hear from you. In addition to hearing from the public on a number of really important topics to universal healthcare, we also try and solicit presentations and information from subject matter experts. And you can see some of the topics that the commission has had the opportunity to have experts come and speak to them on and help us better understand these from both a national and state level, as well as kind of a community focus level. As we know, Washington has, it's very regional in terms of its healthcare needs. What we need on the east side of the state is different than we need on the west side of the state. Our rural communities face different challenges than our urban communities in terms of access. So much of that information has come from presentations by subject matter experts on these topics. And we have on our Universal Commission website access to all prior recordings of the Universal Commission. So if you are ever interested in looking back at any of those presentations, we encourage you to do that, and we can drop the link to the Universal Commission's webpage in the chat as well, just so you have easy access to that. So again, thank you for the opportunity to present here today, and looking forward to taking your questions. And I will hand it over to Mary for the rest of the presentation.
Right. Thanks, Ross. Good morning again, everybody. I'm going to dig a little deeper into how the commission is going about its work. And I know there's a whole lot of information on this slide. And if you attend the commission meetings, you've probably seen this as we've been updating it. This lays out the various pieces of the universal system, the transitional solutions that the commission is working on, and also legislative reports. We submit an annual report to legislature every year. There's other reports we've worked on as well. So we try to show this as a nice snapshot of where we are. The green means it's done. The yellow means it's in process. The gray, we haven't gotten there yet, dividing things into phases. I think this slide gives a good idea of how complex it all is and all the pieces you need to think through, and each one depends on the other. So we're making our way through. So I will move on from this one because this one, again, is a lot of information. And I want to point out that in one of its recent meetings, either the end of 24 or the beginning of 25, I don't remember when, the commission sort of split 2025 into two pieces. And they said, we'd like to spend the first 6 months of 2025 really focused on universal system design. And then in the second half of the year, we want to pick up the transitional solutions again, things like administrative simplification. They made that decision partly because this is a pretty big year for the legislature, and that's probably putting it mildly, as you all know. And they said, well, let's see what happens in the legislature this session. Let's see if they address prior authorization or these other things. And then after that shakes out, we'll go back to the transitional solutions. So here's where they are and what they're making their way through. I'm going to talk through each one of these pieces. One that was green was eligibility. This is a topic in a slide that can get me in trouble if I'm not very careful in the way I talk through it. I will say at the outset, there is no intention at all to exclude anyone from a universal system. That is not the point of the commission. The point of universal system is to be universal and to include everyone. Having said that, there are some pretty big roadblocks having to do with federal authority, having to do with state authority, that make it very difficult to include certain groups as the federal laws and regulations stand right now. So what the commission has done is said, okay, we still have our eyes on that. That's still the goal. But in the meantime, let's look at who is more feasible to include in this system, the system we can get, that can be, I don't know, phase one, version one. I'm not sure what to call it. Let's look at the people more feasible to work into that system. And then perhaps as federal law changes and as other things change, we will be ready to go. We'll be all set to go to add in the rest of the population. So, sorry, I'm just looking at I'm getting distracted by the questions. I shouldn't do that. So anyway, the people who are most likely to be included in this first iteration, we define them by where their coverage comes from now, which is Medicaid, people in the individual health plans, that's things like the Washington Health Benefit Exchange, fully insured employer-sponsored plans, not the self-insured, but the fully insured, the PEB-SEB plans, public employee benefits, school employee benefits, and the people who are currently uninsured. So that's our first cohort that we are looking at. The goals for 2025, these things were all yellow on that slide. Complete the analysis of benefits and services, and then determine the prioritization of benefits and services. We have some recent reports and some cost models. The cost of providing 3 different benefit packages to our likely population. A set of recommendations for cost containment mechanisms. We really need to slow the cost growth. There are ways to contain costs. There are pricing mechanisms to keep the cost down. And recommendations for provider reimbursement and participation. So these 3 pieces are very interconnected, and the Commission is working on them all simultaneously. As I mentioned, they'll be picking up their transitional solutions the second half of this calendar year. And those are a number of things they have looked at. They supported reference-based pricing for PEB-SEB plans. There was a bill introduced in the legislature this session. Reference-based pricing, you pick something as your reference point, usually Medicare rates, and then you say to hospitals or other providers, you can charge up to 200% of this rate for this population of people. And that's a way to contain the costs and keep the costs down. They supported expanding coverage for people with certain immigration status. That was referred to as Apple Health expansion. It's Medicaid-like coverage for people who are undocumented. They are supporting integrated eligibility systems, the cost growth targets that Ross mentioned, the Healthcare Cost Transparency Board. That board has targets. And part of every meeting, if you've sat in our meetings, we have a state agency report out. So we have people on the commission representing 5 different state agencies, and they will report what they are doing in this area so that their efforts are aligned. 2025 priorities, administrative simplification, particularly looking at prior authorization, which providers have told us is very onerous and time consuming. We know that patients find it difficult to navigate the prior authorization process. Also increasing provider participation in public programs. So that gives you an idea of where the commission is right now, what they're working on right now, what we're trying to get to by the end of 2025. The goal is to address financing in early 2026. This is my last slide, and I will also put let me put the link in the chat, see if this works. That's the webpage of the commission where you can find meeting materials. You can find recordings of past meetings. There are information about commission members. It's also where a week ahead of time we post the material for the next meeting, so people know what is coming up. We welcome public comment. There's generally a 2-week cutoff before the meeting if you want your comments included in writing. But up until the previous day, register to make spoken comment during the meeting or come to the meeting and put up your hand. So, we try to have plenty of time and space for public comment. And that's true for the commission meetings and for the FTAC meetings. We structure them both the same way. Whoops. All right, that is my last slide. And for some reason, I'm not going to the very last one, but I think this is where I cede the floor and we get to questions later.
Well, yes, thank you very much, Ross and Mary. Now we'll transition and learn about what's happening in the labor movement and nationally, thanks to our special guest, Rose Roach. Are you ready, Rose?
I think that I am. Let me just make sure that I can get up my screen here. And hopefully you are seeing what I'm seeing. Are you seeing the screen, the slide and not the notes page?
Right.
All right, thank you. Well, greetings of solidarity and health from your allies here in Minnesota, the middle of the country. And to the public employees that are here today, especially with what's going on right now, I want to thank you for your service, for your commitment to excellence, and your belief in public goods as a critical part of a functioning, humane society. I spent 25 of my 34 years in the labor movement before retiring in 2023, representing public school employees and public nurses in Minnesota and California, and I know how dedicated public employees are to delivering the very best for the rest of us out here, the public. And also a thank you for this wonderful opportunity to talk with you today about an issue that we all face, a system we all interact with, and the possibility of a different way in which to finance and deliver that system that centers patients and providers, not corporate CEOs and dividers. And that system is, of course, healthcare. I want to begin the presentation by taking a look at the realities of and the problems with the current system, then address the system from a labor perspective and the system's impact on workers and why it just makes sense for labor to engage more directly in the campaign to win an improved and expanded Medicare for all. And then I will end with the solution. So let's get started by identifying the problem. So the healthcare system is centered on making money. And that is very obvious when you look at these recent news headlines. Health insurers gave $120 billion to shareholders while denying your claim. How health insurers racked up billions in extra payments from Medicare Advantage. It was stunning bipartisan anger aimed at Medicare Advantage care denials, the racketeering that happens inside of PBMs. And United Health, employer of the slain executive Brian Thompson, found to have overcharged some cancer patients for drugs by over 1,000%. And then there's this. Goldman Sachs asks in biotech research report, is curing patients a sustainable business model? I mean, seriously, I think that's what literally a healthcare system is supposed to be focused on. But this is very telling about the American healthcare system. A system that works to maximize profits has resulted in merger mania and created a healthcare marketplace more than a healthcare system. This graphic really demonstrates how concentrated the U.S. healthcare marketplace is. 7 large corporations pretty much control all aspects of healthcare, except actually providing that care. They call themselves managed care organizations, but in reality, they manage money. It's our care providers that manage our care. And I want to take a moment to talk about the impact of this marketplace system on racism as a public health crisis. This system prioritizes profit over patients. It also, therefore, perpetuates systemic and institutional racism. Racial and ethnic disparities result from institutional racism, including historical underfunding of care for communities of color, ongoing wealth and income gaps, and suppression of voting and political power to address those inequalities, have led to higher rates of morbidity and mortality for Black and Brown Americans. And through Medicare for All, we can begin to address these inequities by providing truly universal coverage, birth to death. Payments are based on global budgets that reflect overall regional health needs while facilitating the gradual redistribution of funding among hospitals, directing more resources to communities who are most in need. Regular reporting of healthcare disparities would be implemented, which can help to facilitate addressing those disparities in a much more readily way. The focus on our system for the last half a century has been on incremental market-driven tweaks that have failed miserably, yet these failed strategies continue to dominate the healthcare reform debate today. These market-driven reforms are known to us, as I said earlier, as managed care. Many health economists hold to the idea that excessive healthcare costs in the United States are due to 2 things: physician greed and patients getting too much care. In other words, that the fee-for-service model incentivizes and pays for excess care, that we should pay for value, not volume. Sounds so logical. Who doesn't want to make sure we're paying for quality? However, that's not happening under this system, and there is absolutely no evidence to show that it is happening, and it's incredibly insulting to our care providers. In fact, this inaccurate diagnosis that we somehow overuse healthcare in this country simply because we pay for it based on the fee-for-service model ended up doing nothing to contain costs and has actually done the exact opposite. It has driven prices up through added administrative costs and through market consolidation. You cannot use market forces to control healthcare prices because healthcare isn't a consumable good. So what is driving costs? Well, to quote the late Uwe Reinhardt, a Princeton economics professor, it's the prices, stupid, and we're never going to get a handle on the prices until we fix the financing of the system overall. The focus being on money versus health has pretty much resulted in this playing out in doctors' offices all across the country. Well, why don't you tell me the problem and I'll tell you if it's covered? I'm sick. Nope. Not covered, right? That's how many of us feel. The rapid corporatization and privatization of the healthcare system has infiltrated pretty much every program of our public health programs, with Medicare being the most egregious example. Medicare Advantage is neither Medicare nor much of an advantage. It is the misleading name for private insurance plans that are paid Medicare dollars to care for Medicare enrollees that they entice to choose their Advantage plan over traditional Medicare with a Medigap or supplemental plan. Problem is, through the Medicare Trust Fund, we are actually subsidizing these private insurers as much as $140 billion a year that they're getting that isn't actually going to enrollees' healthcare needs. They're gaming the system. Just this week, the Committee for a Responsible Federal Budget has determined that Medicare Advantage will be overpaid by $1.2 trillion between now and 2034. I'll answer the question I pose on this slide about what could we do with those funds when I get to the solution section of the presentation. Advantage plans upcode enrollees to make us appear sicker than we actually are, because that way they can get more money from Medicare. And this is draining our Medicare fund of billions of dollars. These privatized plans are not saving Medicare money. On the contrary, the Kaiser Family Foundation found that Medicare Advantage has never generated savings relative to traditional Medicare. In fact, the opposite is true. Concerns about the issue of overpayments also crosses party lines in Congress. There is bipartisan support to do something about this, which is very encouraging. In addition to costing the Medicare fund more money, Advantage beneficiaries across the country receive overall less health care than those in traditional Medicare with a gap plan. Prior authorizations. These exist within Advantage plans and are running rampant, causing delays and in some cases outright denials of care. And as we all know, a delay in care can be catastrophic for someone, depending on what it is that they are dealing with as far as illness or injury. And, oops, I'm sorry, what happened here? Why isn't my slide showing the, oh darn, something happened with my slide, but I can just simply tell you that prior authorizations are being implemented at the rate of 1.8 per person versus traditional Medicare, where a prior authorization is so rare, it only occurs in 1 per 100 people a year, not 1.8 prior authorization for each person each year. So dealing with these prior authorization abuses also has some bipartisan support in Congress. This is extremely important to note. Within corporate Advantage plans, death rates double after some cancer surgeries. 7.3 million people are left uninsured in Advantage plans. They have found that in many cases, you have the exclusion of most. 70% of all the physicians in a county are excluded from Medicare Advantage plan. This is really wreaking havoc in rural America, as we are seeing more and more hospital closures or services being shut down. And in many cases, the hospital systems are saying, we're just not going to accept Medicare Advantage patients because we don't get paid for the services we provide. And that is just not okay. We are also seeing up to 20 million hours per year being wasted because care providers have to fight with insurance companies to get you the care that they, the healthcare professional has determined that you need. This is all interconnected in a way that harms patients directly. So what does healthcare look like with that being sort of the basis from a labor perspective? Well, in this country, unlike any other, access to healthcare, as we know, is connected to employment. Therefore, it's a term and condition of employment. So organized labor negotiates over healthcare as a benefit. There's no question that unions have helped to shield working families from the efforts of corporations to dump healthcare costs onto the backs of individual workers. We know that most union members have better healthcare benefits than non-unionized workers. However, the truth is, we still don't get all services covered. We have to buy separate insurance for our teeth and our eyes in many cases. We are suffering wage stagnation because there's a limited amount of funds on the bargaining table, and so much of it ends up going towards paying for increased premiums or going back and forth and fighting with the employer over a plan that has higher deductibles. Are we paying for the additional costs in the front end, or are we going to roll the dice and hope we don't get sick and get hampered with a huge bill and have to deal with a $7,000 out-of-pocket deductible? It's really been a problem for us at the bargaining table. And of course, limited providers, because we're in networks, and all of those things none of those are healthcare strategies. All of them are business strategies. And it really does ask the question of, does that make any sense for us to keep thinking we can negotiate healthcare? And the impact to wages that I mentioned on what is happening at the table because of the costs in these premiums in particular, you can see here on this graph, the orange line is the increase in premiums over the course of 1999 to 2021, compared with the dark blue line in the middle, which is actually the overall inflation, and the light blue is the rise in cost of family premiums. So this alligator mouth is unsustainable for workers, businesses, government, and quite frankly, our economy overall. This slide is a bit outdated, but it illustrates what we're up against when we try to bargain health benefits. And running this graph out to 2024 would only show you that medical costs for a family of four are continuing to rise. What this means is that since 1999, premiums have increased by 213%. For workers, they've seen an increase in their contribution to this so-called benefit of 242% for that same time period. This is just unsustainable. Even for those with employer-provided insurance, 200 million claims per year are denied. The reality is the insurance companies are making money by denying health care. It's the only way they can. And this whole system is wreaking havoc for retirees in particular across the country. And corporate advantage plans within Medicare then become a tool that is used to divide and conquer us, pitting worker against worker. Whether we're at the table negotiating for active employees or whether we are trying to negotiate benefits, health benefits for retirees, it's exactly the same. The negotiations for us at the table with the bosses are identical to one another when it comes to this issue. So what's the solution to this convoluted mess? And to be clear, all the connections within this mess affect all of us by adding costs and creating barriers to care. How is any of this good for the working class? We do not need this complexity. We can instead move to this: a streamlined payment system that is publicly financed, privately delivered, and in doing so, workers can halt wage stagnation caused by trying to fund a system that has no rhyme or reason as to how it is financed. As Ross had said earlier, there are different ways to set up universal health care, Medicare, but again, I want to just state that Medicare for All as a single payer system would be publicly financed and privately delivered, so it begins streamlining the payment process, establishing global budgets for hospitals based on community need and not on corporate greed, providing capital budgets for infrastructure needs while removing personal financial barriers to care and allowing us to deal with the problems that we have in care delivery, because we do, and we have to get to that, with also dealing with health disparities, particularly racial health disparities, and put an emphasis on being a healthcare system versus a sick care system. On the Medicare privatization front, the solution to the naked profiteering within Medicare is to level the playing field between corporate advantage plans and traditional Medicare. Remember, I said the estimate of how much those corporate plans are being overpaid ranges from $83 billion to $140 billion a year. And when I say we can recapture that money and redirect it to improve and expand Medicare, traditional Medicare, you can see here that we can do that by reallocating 85 billion, meaning that would be if we would go ahead and implement a $5,000 maximum out-of-pocket cap on Medicare. So potentially gap insurance wouldn't even be necessary, depending on whether you could afford that 5,000 out of pocket. But remember, we're paying probably half of that at least in the cost of gap plans, right? A couple hundred a month to pay for the gap plans. We could add pharmacy. We could add dental and optical at the Medicare Advantage level, which isn't the best, by the way, but at least it would mean that traditional Medicare would match the Medicare Advantage benefits and put us on a level playing field. So this is a reallocation of funds. This is not an ask for additional, federal or tax dollars. It's already in the system. And that is why the Labor Campaign is a member of the Reclaim Medicare Coalescence, whose mission is to stop further privatization of Medicare. The coalescence includes organizations that may not be fully on board with Medicare for all, but they are deeply concerned about the destruction of Medicare and Medicaid. So we've found common ground on which to work together on. On the Medicare for all front, the fact is that health insurance benefits are nothing more than a transfer of our wealth as workers to the corporate bosses, which, as I said, has caused decades of wage stagnation. So why should employers really, when you think about it, why should employers control our access to health care? That doesn't make any sense. Labor should support single payer or Medicare for all so we don't die younger than we need to because everyone is covered. Medical needs include every part of our physiological and psychological body. It takes control of our access to healthcare out of the hands of our bosses. It reduces costs by cutting administrative waste, not by denying care. It pays those who do the work fairly and in a timely manner. It's a simple and understandable payment system. Medicare for All provides a just transition for those who do administrative work within the current system that would no longer be needed. Let's stop wasting money. We can make healthcare affordable by ensuring premium costs are based on ability to pay. We know, based on numerous studies, that a Medicare for all type system does four things. It saves money, it covers everyone, it improves quality, and most importantly, it saves lives. Oops, I'm sorry. Single payer Medicare for All delivers. It delivers real freedom by allowing us to choose our doctors, clinics, and hospitals, not to have an insurance company dictate that choice to us. It delivers the pathway to equality and an end to racial bias in the funding and delivery of care. It delivers health justice through a progressively paid for system that covers everyone, no exceptions. And it delivers security because it's access to affordable health care, as I like to say, from womb to tomb. The Labor Campaign for Single Payer is a partner also in the National Medicare for All Coalition, consisting of national community and social justice organizations across the country. A number of national unions are involved, including National Nurses United, as well as Physicians for a National Health Program. As we begin to develop a national strategic plan to win Medicare for All within the next 10 to 15 years, we have four areas of focus. Anti-corporate work, because corporations are literally killing us, and we need to be talking about that. Communication to develop a common narrative for our work, and of course, grassroots organizing and coalition building. And in 2025, we have some great opportunities for action and organizing. There is a public campaign. United Health Group happens to live right here in Minnesota in my backyard, and we have been there a couple of different times doing actions outside of their offices with patients from around the country talking about how they're being denied care and how it is putting their lives at risk. We've got these absolutely draconian potential Medicaid cuts that are coming down, cuts to the ACA subsidies, those advantage overpayments I referred to earlier. July 30th is going to be the 60th anniversary of Medicare, so we could do a celebration around that. We've got pharma drug price negotiations that will hopefully continue to happen. And the reintroduction of the Medicare for All Act, which we just found out is going to be on April 29th. And I'm very lucky to be able to be going to DC for that reintroduction. So in other industrialized nations in the world who provide healthcare for all their citizens in some way, the unions in those countries have figured out that they can't keep their own healthcare benefits without everyone having healthcare. Working conditions, childcare, elder care, restoration of defined benefit pensions, wages themselves. There are plenty of terms and conditions of employment that workers and their union have to confront to make the workplace safe, productive, and non-toxic. These are the kinds of issues unions in countries with some kind of universal health care are able to focus on because health care is literally off the table for them. Medicare for all really is the ultimate act of solidarity. So I just want to provide these final takeaways. Change is coming to the United States healthcare system. It's imperative that the labor movement be prepared to shape the change to serve our members and all working people. The $4.5 trillion that we are currently spending on healthcare could be used to pay for a system that's based on humane principles. Improved Medicare for all would take healthcare off the bargaining table, allowing us to use our bargaining power to improve wages, pensions, and working conditions. In the last 40 years, the ultra-rich have robbed working people of trillions of dollars of wealth that we created. Medicare for all is one way to take some of that back and give us a pay raise. If we're going to make such a massive change in our healthcare system, we need to ensure that workers in healthcare, the healthcare administration, and the insurance industry are protected. And we do that in the Medicare for all bill through a just transition. Does improved Medicare for all sound too good to be true? That's why the opponents spend tens of millions of dollars, if not hundreds of millions, to attack the bill. But we need to fear the status quo, not fear the change, because the status quo is financially, emotionally, and literally killing us. We're going to get you these slides. So I want to encourage you to access our website, sign up for our monthly newsletter. We just did an incredible briefing the day before yesterday in DC with a whole bunch of national and international union presidents and their staff about the perils of Medicare Advantage. So we're going to have a white paper available that even includes some good tips for if you are at the bargaining table and Medicare Advantage is on the table. So I want to end by saying that it is time to call the question in this country and for labor to call the question, is healthcare a benefit or is it a necessity? Tying healthcare access to employment is a failed strategy and it makes zero economic and humanitarian sense. Our access to healthcare has become a weapon in the class warfare that we are all engaged in. Our job as trade unionists is to make healthcare for all politically possible by moving from resolutionary politics to revolutionary politics, from transactional presentation to transformational change. And we do that by building a powerful worker, patient, provider, people-centered campaign because as the grasshopper in the movie, A Bug's Life stated, you let one ant stand up to us and they all might stand up to us. Those puny little ants outnumber us 100 to 1, and if they ever figure that out, there goes our way of life. Well, guess what? We figured it out and there goes their way of life. Si se puede, everyone.
Wow. Thank you, Rose, for those important insights. A lot of us know at least parts of what you've presented, but having it all together in one package, that's pretty helpful. Thank you very much. Now we're going to begin the Q&A period of the program. Matt will pose the questions from the healthcare work group. So Matt, whenever you're ready.
Yeah. Thank you, Claire, and thanks to our presenters. And my first question is for Rose. I'm chair of the Healthcare Work Group in RPEC, a very hardworking group of people who meet twice a month trying to unravel the complexities of the healthcare system. And if there's anything we know, everything is extremely complex. Nothing is simple. It's this hodgepodge system. I loved your slide of the, what was it called? The healthcare that's how we feel constantly. So, at the very end, you also mentioned that the powerful corporate interests spend tens of millions. They could spend tens of billions of dollars if they wanted to fight common sense solutions for the great masses of people that threaten their corporate interests. And you mentioned multiple times about the, let's say, $100 billion extra paid to our beloved Medicare Advantage insurance companies. I looked up the average salary also, because I'm sure the AMA would scream bloody murder. The average salary of an orthopedic surgeon in Seattle, the average is $610,000 a year. So there's big money against this. So the question is, how do we fight that, given the current political climate? And thank God for labor, but there definitely has been an ascendancy of corporate power. So how do we fight this and get towards that common sense solution?
Yeah, I think it's a very important question, and thank you for sending it ahead of time because I wanted to think that through. So I jotted down some thoughts about that. I think that the main reason that healthcare reform is so hard is because we are, in fact, confronting, as you said, concentrated corporate power. And when the politicians actually tell us that Medicare for all is not politically feasible, what they really mean is that we are not powerful enough yet to prevail against them. Healthcare, however, does occupy a unique position because the policy has such deeply personal consequences. So it is and can be a wedge issue that opens the door to a broader anti-corporate politics. But quite frankly, we are unlikely to win Medicare for all without a broad social transformation. Think about it. Can we win Medicare for all when the minimum wage is still $7.25 an hour? We have to do better in connecting Medicare for all to those kitchen table issues that cross political ideology. How will Medicare for all help raise wages for the working class? How will it help businesses expand so they can create more jobs? How can Medicare for all help the working class pay their rent, their mortgages? Stories are also, of course, a key part of moving Medicare for all, but the stories only have political impact if they are based on framing such as claims are denied for the sole purpose of making a profit. We have to connect the dots. Stories of prior authorization hassles put into context as to how commercial insurers created prior authorizations in order to limit care and therefore limit their expenses. It doesn't really exist, these prior authorizations under traditional Medicare. We're also dealing with ideological resistance and solidarity among corporations themselves, many of whom would actually benefit financially from Medicare for all. But they oppose government as the sole payer, and they don't want a public payment for services to replace a market-based system. And this general ideological belief that the market is always right and always good and can always do it better. Individual choice is distorted and it's used against us, but it reflects a gut-level sense that Medicare for all is collectivist in a way that the present system is not, running up against the bedrock American ideology of this, hyper-individualism. And there is the real issue of loss aversion, that even with a strong case against the present system, people are inherently skeptical of replacing what they have with something lesser known. That's why changing the narrative to one of collective abundance by freeing individuals, families, businesses, and even government of the current albatross around their necks of a profit-driven, employer-based healthcare system is key. As we say, the policy, the economics, and the morality are on our side, so what is missing? Well, it's a political strategy around a movement which, if we are taking on corporate power so directly, can really only succeed if it is led in this country by labor, by the labor movement that lifts up all workers, really, and all of society and our economy at the same time. I want to just remind everyone, as we experience these bleak times, that much of Europe won national health care in the immediate post-war years, which saw an expansion in social rights and public goods following the defeat of fascism. They were able to do so in part because the corporate elites and their institutions were so discredited and weakened by their servile acquiescence to the fascist rule that they couldn't put up effective resistance. Perhaps the movement that is strong enough to defeat authoritarianism in this country will also be the movement that finally establishes the right to health care.
Thank you, Rose. I'm reminded of the progressive movement around the 1900s. You know, the graph goes up and down,
Yes.
and let's hope we get to the top of the graph soon. Thank you. And questions for Ross and Mary. This is from Aruna on the healthcare work group. How can Washingtonians be sure that universal healthcare implemented in Washington will be single payer without health maintenance or managed care organizations or any other insurance plans?
Ross, do you want me to jump in and start us
Yeah,
out?
go ahead, Mary.
Yeah, that's a very good question. I would say keep informed on the efforts of the commission, keep speaking up at the commission, keep speaking up at FTAC. There are advocacy groups that are Washington specific that are working toward single payer. You know, I would be remiss if I did not mention what it says in the RCW for the commission. And I'm not saying this is the commission's position, but I'm saying this is the commission's charge from the legislature. It says a unified, working toward a unified financing system, including but not limited to single payer. So I can tell you, so I think that makes it clear the legislature does not consider single payer a foregone conclusion, which means if that's, keep talking about it, keep bringing it up to legislators, keep bringing it up, involvement with advocacy organizations, what Rose described as national level. There's also efforts at various state levels. I don't see this as either or. I see this as keep up the pressure and something will give if that's your goal. And I also would, I'm going to get kind of in the health policy weeds here because that's where I live. If you are talking to legislators or talking to commission and making a case for single payer, which there's a lot of good reasons to make a case for single payer, try not to talk about it in isolation. If you think about the slide I had of all the pieces the commission is considering, think about how this would affect the administrative side, because the administrative work isn't going to go away. Ideally, it will be greatly reduced. I don't think it can be eliminated. Or where does the funding come from? I mean, if you talk to a legislator and say, we want this single payer, I think the next question you're going to hear is, well, where does that money come from? So I would suggest maybe trying to talk about it as all of a piece of a bigger picture. But again, that's when you're with the advocacy groups and the commission and the legislators and the people whose focus is in that realm. I don't know, Ross, if you wanted to add something.
No, I think that's great, Mary. I mean, it's the boring answer, but it's the accurate answer, is that the legislature directed us to analyze what would be necessary to get the state ready for a unified financing system, not limited to single payer. So I completely agree with what Mary said. And as we're speaking to retired public employees, I think all folks here are aware that as public employees, we have to follow the law and we're guided by what the legislature directs us to do. And so that is the direction that we're operating under now. And also highlighting what Mary said, not to the exclusion of a single payer system either. That's very much part of what we're analyzing through these different steps in the phased process that Mary discussed for the Universal Commission. So not excluding single payer by any means, but our obligation to the legislature is to evaluate different models, including single payer. So completely agree with what Mary said in her recommendations for kind of advocacy around, if you have a preference for one or the other, the different ways that you can advocate for that, or to submit public comments to the board, where those things can be commission, and those things can be kind of considered in that context as well.
Thank you. The second question, it was partially answered during your excellent presentation. do you envision Medicare employer group waiver plans being incorporated as part of a universal system? And you said that that was one of the low-hanging fruit plans that could be used in an initial step, if I'm not incorrect. But might it also change the eligibility for PEB? All the state retirees are in PEB. SEB is for active, I believe. So would PEB, might eligibility widen to other groups in the state that are currently not covered through PEB?
Was that for Mary and I, Matt?
Yes.
Okay. Mary, I'll take big picture on waivers, and then if there's any more nuance around that question regarding PEP/SEB, maybe you can take that part. Again, I've been in this position for 11 weeks, so I apologize if I'm not capturing everything, but just big picture starting responding to that question, Matt, because I think it is possibly the fundamental question that's part of unlocking the kind of universal healthcare is the waiver process. And there's certain federal laws, I guess I'll just highlight ERISA as something that there would need to be changes on a federal level to bring in that swath of employer-sponsored benefit plans, or the individuals that are currently entitled to those benefits, to allow the state to be able to pull those in. So like using ERISA as an example, there is not currently waiver authority for ERISA. So there would need to be a federal amendment to create the ability for a waiver to waive some of the provisions that preempt states from regulating employer-sponsored benefit plans. So that would, like using ERISA as an example, is kind of a two-step process where there would need to be the creation of the ability for a waiver or a change to the federal law to allow states to be able to regulate employer-sponsored welfare benefit plans. Using another example, so that's probably one of the most complicated areas of federal law in waivers impacting universal health care. Also confusing, but a little bit more well understood, is Medicare, which does have current waiver authority. And so there is some experience on the state level of working through those types of things, more historical than recent. So there is existing waiver authority for Medicare. But again, that would be a process of the state having to apply. It's quite a laborious process to get a waiver from that. So just to kind of highlight, for each kind of bucket of insureds or patients, kind of however you want to think about it, there's a separate waiver process that would need to be complicated or contemplated, likely, kind of as I was noting. ERISA has a different set of complications than Medicare might. So that's part of the commission's work, is kind of analyzing each of these different bodies and thinking about what would need to happen and what we would need to do to prepare the state to be able to move forward with a universal system. And I think Mary can probably talk more about the specifics regarding PEP/SEB.
Yeah, thank you, Ross. Yeah, I just want to, I did note in the chat as I was speaking through the eligibility slide, there was the question, what about people on Medicare? I hope Ross's answer covered that there is a waiver process, and waivers take a very long time and a lot of negotiation. So, one thing that we have considered is, if we know that there is, these federal preemption, federal regulations making it very hard to regulate a plan for the big self-funded ERISA governed plans or for Medicare, that you could design a system so that there could be pieces of it that people could opt into. Not that the state would ever, in the big self-insured plans, the state does not have authority. But, you could create something that might be attractive enough for people to opt into, or attractive enough for the employer to choose instead of what they are currently doing. That is one approach. What was the PEB/SEB question? Sorry, I think I lost the details of the question.
Oh, it would be, if PEB is going to be included in this first round of groups that the commission is going to try some things on, might that create an opportunity for the eligibility for PEB retirees to join the plan, might that be widened to include other groups, or maybe retirees who worked for the state previously in their career but did not work clear up to retirement?
Okay.
And I understand that's by statute, but I'm wondering if the political context changes with a more universal healthcare availability.
Yeah,
I don't know if that makes sense, but
yeah, I mean, I think it's certainly a possibility. Again, if you think about what was listed as these are our likely eligible groups in our initial go round. Another way to interpret that is these are the areas where the state right now has greater regulatory authority, right? Medicaid, PEB/SEB, individual market. This is where the state has more sway. So I think the answer is that it is possible with the PEB/SEB plans also to broaden it, because the state governs PEB/SEB.
okay, thank you.
Mhm.
I think
Matt,
so that other
Matt, it
people
looks
get
like Matt, it looks like Rose has something she'd like to offer on that topic as well.
Okay, great. Thank you, Rose. Yeah.
If you don't mind, I put in the chat that I also am chair of Healthcare for All Minnesota. So we are working on a state-based single payer plan here as well. And this question of ERISA and Medicare and waivers, and this is just kind of a nightmare for all of us, right? Especially because we don't know whether we would get any waivers to do any innovation right now, considering the federal government doesn't look like they're interested in doing that. I think with ERISA, the thing to keep in mind, I mean, we're not, if we don't, unless we get that state-based universal health care national bill that Ro Khanna is the author of in Congress passed, that just gives the states automatic waivers to do this. If we don't get that anytime soon and we start to be able to innovate in the states, I think the ERISA question is what it is, and it is true that we will not be able to force those big self-insured employers to be part of the state system, but I will tell you that it's just going to be financially stupid for them not to. Why? Because they are going to be taxed. There is no way to do this system unless it is through a tax system, through tax structure, and everybody's going to have to pay that, employers, employees, et cetera, et cetera. And however we structure that, so why would they pay double? Why would they have their own system that they're paying for while they're also paying into the state system? That economically makes no sense. Maybe someone will do it because they want the power over their employees as continuing to have that so-called benefit, but that is what it is. On Medicare, here in Minnesota, we're kind of looking at it like, you know what? If we pass our Minnesota Health Plan, that's the name of our bill, it'll just be basically the GAP plan. It'll be the wraparound to Medicare. We're not asking for Medicare funds to be part of our system. Leave Medicare alone as a national program. The same with Indian Health Services and VA. Those are federal programs. So the idea would be anything that you don't get covered in your federal program, the state program is going to pick up and be your wraparound. So that's another way to think about it or look at it, at least how we're thinking about it.
Thank you. And I'm going to cede the last question so other members can ask their questions. I just want to acknowledge Judy Finn, who is a member of our healthcare work group, who attends all of the Universal Healthcare Commission meetings and reports back to the work group and writes reports that go to RPEC state leadership, and she does a tremendous job. So I just want to acknowledge her. And with that, Claire, I'll give it back to you. Thank you.
Thank you, Matt. Derek Van Spoor, Associate Director, and Alyssa Brady, Project Coordinator, have been monitoring the chat and will now pose the questions from chat to the presenters.
All right, thank you, Claire. First, we have a handful of questions here that we'll present, and then if we still have time left, we'll open it up to the floor for any questions remaining. The first one was from Chris Curry to HCA. Why, after the UHC work group did so much good work on narrowing the options and issues and analyzing the costs, did the commission not use that work as its starting point by choosing the recommended Model A single payer as its framework?
Yeah, I can jump in on that. Thank you,
Sure.
Chris, for the question. Ross, you can, if you want to add on, please feel free. Though what Chris is referring to is an entity that preceded the Universal Healthcare Commission, which is the Universal Healthcare Work Group. Did a lot of research, a lot of laying the groundwork, what turned into the commission's charge. Model A is a single payer framework. We often refer to Model A and Model B. Model B was a multi-payer. Chris, I think I'm getting this right. Jump in if I'm getting this wrong. Model B would be the state and health plans multi-payer system. Now I'm going to talk about work that happened that I was not part of, but as I understand it, so this is the best I can do for you right now, Chris, is that it does lay the groundwork and those options are still on the table, but the commission was not prepared to go all in on single payer at the beginning of its work. And that's an assumption on my part, and I'm going to give you an unsatisfying answer because I'm not actually sure why they did that. But I can only say that all of these frameworks are still on the table. It's still working through. It's still working through infrastructure and governance. Ross, I don't know if you have anything else to add to that.
Well, just the boring part, which is this is what the legislature directed us to do. I was just dropping that in the chat. Again, I think in my presentation, we had discussed kind of the two directives the commission had from the legislature, monitoring growing healthcare costs, as well as establishing or getting the state ready for a unified healthcare financing system. And so I know that's not the most satisfactory answer, but I will say on a pretty routine basis, there's still folks that were involved in that 2019 process. They're still active with the commission and kind of keeping some of that conversation going. And I think the commission has done a nice job of continuing that discussion. And honestly, coming to this work, I was a little mystified by the directive that I just added to the chat. I thought it was a little strange that we didn't decide to go full steam ahead, that it was this kind of analysis to understand what we need to do to prepare the state for a unified healthcare financing system. But as I've worked with the commission and their technical committees, really getting a good understanding of the number of questions and challenges and work that they're doing to really have good, solid answers to a lot of the questions that you're asking, that other folks answer, and really taking the time to fully understand what it would look like for Washington to have a universal system, what it would take, analyzing some of these tricky federal questions regarding waivers, but also, the individual more minute questions about eligibility and plan design and benefits. So again, this has been a very strategic, incremental approach. And that's kind of what the legislature has advocated. And again, from my perspective, I've seen a ton of benefit in kind of taking this very tactful approach where we're really developing a strong body of evidence to support the direction that the Universal Commission is going. So in conjunction with the legislative direction, starting to really understand and see the benefit of looking at these questions individually at depth with financial experts and members of the community and kind of bringing that together at the commission level to discuss.
Thank you. This next question is for HCA from Michael Ruby. There are frequent comments that the pool that is Washington residents is too small to be stable. Is the commission working with Oregon to determine how we could have a bi-state system?
I'm happy to start off, Mary. You can jump in as well. The direction again from the legislature is providing coverage and access for all Washington residents, and that was kind of our legislative directive of what we're considering. With that being said, though, the commission has done a lot of work with both external subject matter experts as well as just routinely discussing and meeting with members of their Oregon department, in discussing kind of the similar issues that we face. And we certainly have a pretty similar healthcare market too, as well, between Washington and Oregon. Oregon's a little smaller, but so acknowledging that there are some synchronicities, between our process and theirs. But to my knowledge, and Mary, correct me if I'm wrong, there's not an explicit directive to partner with Oregon in this process to consider kind of a two-state universal system. But Mary, if I got that wrong, please correct me.
No, I agree. None that I know of, although as Ross mentioned, we are in close contact with Oregon. They have a different name for their commission. I think it's called the governing board. I don't know. Maybe some other folks know what it is. I don't know what it's called in Oregon. But we're in touch. We compare notes. There's a lot of reciprocity between Washington and Oregon on a lot of matters related to healthcare. So we are in touch and aware of their work.
Great. Thank you, Mary and Ross. This next question is for Rose. Again, from Michael Ruby. It seems that Kaiser Permanente is not milking the Medicare Advantage system. Could you give your opinion on the correctness of this statement?
Yeah, so I can't speak to, real directly to Kaiser Permanente only because I'm here in the center of the country where we don't have a Kaiser Permanente, right? But I was in California for 11 years, so I'm very, very familiar with Kaiser and the system out there. Look, not every Medicare Advantage plan provider, is doing some of the stuff that I showed. Right. We've got one here in Minnesota. It's called UCare. It's connected to the University of Minnesota. It's a nonprofit. And it's actually a decent plan. There's no question about that. It does much, much better. It's very low on the claims denials, very low on the prior authorizations. I'm assuming Kaiser might fall into that same category. And some of that is because when we think about Kaiser, not their insurance piece, right? Because they are an insurance provider, but over where they're a care delivery system, listen, people like Kaiser, that are part of Kaiser. My daughter lives out in California and she's part of Kaiser and she loves it. And because it is an integrated system, right? I mean, if you break your leg in San Diego, but you live in Sacramento, Kaiser knows how to take care of you in San Diego because they can access your medical records. Because guess what? It's a system that's all integrated, right? I mean, that's what we ultimately want to see as a country for that same sort of a system to exist. So I don't know the specifics of the Kaiser Medicare Advantage plans. There are definitely better players and there are bad actors when it comes to this. What we're looking at and in our work with Physicians for a National Health Program is the overall of what we're seeing from seniors across the country in Medicare Advantage plans, and the general consensus is that we are seeing very high levels of these claims denials, prior authorization needs, narrowing of networks, high out-of-pocket costs. People are feeling lied to by these advertisements that come up, and they pick a plan based on that, only to find out a few months later that the drug that they thought was on the formulary has now been taken off the formulary, and now they went from paying $6 a month to $400 a month for a life-sustaining medication that they need. So it's not about it. It's in generalities to some degree, but what isn't general is the fact that the way these plans are operating inside of Medicare to literally rip us off. That is happening and in a very big way. And even if Kaiser doesn't fall in that category with upcoding people and things of that nature, the system as a whole needs to be looked at. Even Senator Chuck Grassley, strong conservative Republican from Iowa, he just wrote a pretty scathing letter to Sir Andrew Whitty, the CEO of United Health Group, and said, what is going on here? What are you doing? This isn't what you promised us was going to happen inside of the Medicare system. You said you were going to lessen the cost and you were going to improve quality, and none of that seems to be happening here. So the system has to be taken, they have to take a look at it. They should not be profiting off of senior citizen suffering. That's just not okay as a part of a system. So I hope that helps.
Thank you, Rose. I have another question for you from Kurt Eschels. I'm sorry if I'm saying that wrong. Are there studies that compare care under Medicare to Canada and other single-payer systems, such as health outcomes, costs, etc.?
Oh, there are tons. The OECD studies, of course, are the most prominent. I think the Kaiser Family Foundation also does a lot of studies. And I would just note that there is no perfect system, by the way. We're human. So a perfect healthcare system doesn't exactly exist. But when you compare us to the rest of, particularly the industrialized nations of the world, most of which all provide healthcare as some kind of a basic, right to their citizens, you will see that we pay the most money and we have the worst health outcomes. There are certain categories where we do a little better on some particular, diagnoses, but as a system overall, we have much worse health outcomes in this country, and we get blamed for it all the time. Well, that's because we're smoking too much and we're not eating enough good fruit, and we're not. And some of that is true. I mean, we could do better, but in most of those other countries, they smoke more, they drink more, they go to the doctor more, and somehow they manage to have a system that costs less, and they have better health outcomes. Do you know in this country, for I think it's the fourth year in a row now, our life expectancy has gone down in the richest nation in the world, and that is adjusted for COVID having happened. That's nuts. We're paying here for a public system. We're just not getting it because so much of the money is reallocated to things like stock buybacks, shareholder dividends, and exorbitant CEO compensation packages instead of allocating it to healthcare. And I will say, the comment earlier that I think it was Matt that said, there's orthopedic surgeons making 600 grand out in Seattle, Washington, or whatever. I'm a trade unionist. I'm always about the person given the service getting the money. And so I don't know if that's a good price for an orthopedic surgeon or not, but I will tell you this, I'd much rather have that orthopedic surgeon getting that salary than Sir Andrew Whitty here of United Health Group making $90 million, and he didn't heal anybody. So we absolutely have to take a look at that. And by the way, I was in Canada a few years ago talking to doctors and nurses up in Saskatchewan, and the doctor told us, he said, you know what? We pay our primary care physicians more money up here than you do in the United States, but it is true, we don't pay quite as much as you do to the specialists. And he said, our specialist, like an orthopedic surgeon here, maybe makes $500,000 a year. And I guess, we're paying $750. So will there maybe have to be a bit of an adjustment there? Possibly. But mostly it is about making sure that the people who are providing the care make the money to provide that care they should. They've given a lot up to help us, save our lives.
Great. And our last question from chat, Rose, is from Elliot Weinstein. How does labor deal with the power of health insurers to pay off legislators?
Yeah, so I'll be probably a little politically incorrect in telling you that labor needs to stop thinking that health insurance has a place or a need in this system to begin with. We're so sort of hooked to this idea that we have to bargain it through these health insurance entities. That's just not really true. Labor needs to be bold. Labor has taken a position saying they want to get to Medicare for all. They have not politically prioritized it. They are not resourcing the campaign to win it. We are never going to match them dollar for dollar in any way, shape, or form. They're far too rich and powerful in that way. But we got something they don't, and that is absolutely people power. And so it is about engaging rank and file members of the unions to understand this is where we need to go. When I was in California, I worked for the California School Employees Association. We had 225,000 members of that union, and we educated 40,000 of them one-on-one as to why single payer healthcare is the way to go and why we need to take healthcare off the bargaining table. And to my amazement, that just spread like wildfire, and those union members hit the streets, and they were out at rallies, and they were lobbying their legislators for that legislation because they understood it. So it's going to take a lot. It's not going to be easy, but none of this is. It's always about organizing and building relationship with one another.
Great. Thank you, Rose. And Mary, you had something to add.
Yep, I know. I'll be very quick. I want to comment on a comment that was in the chat from Alma Jean, talking about the challenge that, people say this stuff, it's boring, it's too complicated, it's too time consuming, it's too hard to talk about. Something Rose mentioned earlier was the power of stories and the power to make this real, because I always joke that you can't, it's really hard to talk about this stuff in the middle. We can talk about the big ideas, the big concepts. Oh, everyone needs to be covered. Everyone needs access. People are going bankrupt with their medical bills. Like big, and then what happened when you asked me a question? I was in the weeds faster than anybody else you ever met. You start talking about the details, and people like me will drag you into the weeds. Ross, you're guilty too. So if we can find that the middle, and I think the stories are in the middle, but I think that's where a lot of the change can come from. I just wanted to acknowledge the comment because I thought it hit the nail on the head.
Thank you, Mary. Rose hit right on it. We need to create a ruckus.
Yep.
You are talking to the choir. We need to talk to the ones who are gone to sleep and who find it boring and uninteresting. Personally, anything that has to do with my income and my welfare, I am not bored at all. I'm wide awake. But I have had to present these programs to employees in orientation and have them tell me that they're bored and they are interested only when it affects them one-on-one. If everything's going fine for them, they could care less. And we need those voices. Communications, marketing, I think, is key, and it's expensive and it's hard.
I couldn't agree more. And if I could just say one thing real quickly. Last fall, I think it was in September, early October, I was invited to an AFSCME retiree council here in Minnesota to give a presentation on Medicare Advantage to their retiree group, and all the retirees in the state of Minnesota are on a Medicare Advantage plan, by the way. And so I gave the presentation. I talked about how the privatization of Medicare is a bipartisan effort. This is not only on Republicans. There are Democrats that are as much involved in this privatization as the Republicans are. And I said, this is just about a fairness issue, right? And it is about making sure that we're not, depleting our Medicare fund. And this guy chased me out after I gave my presentation, and he had a button on. I didn't pay much attention to it because we were talking. He said, geez, this is the most important information we've gotten at this, at this convention. And I'm outraged to find out that this is happening inside our Medicare fund. And I want to do something about it. And then I looked at his button and it said Trump 2024. And he said, yeah. I'm not, I'm not a Democrat like everybody else in that room is. I happen to support Trump. And I said, listen, we found some common ground here. You get to support who you want to support. We found common ground, didn't we? And you don't think this is just, and you don't think this is right. So let's build on that together with each other. So you never know. And healthcare really can be, I think, an issue of intersectionality across the justice movement, but also an issue because we're human and we all need to access the healthcare system. It is one that we can actually cross over even ideological lines on.
Well, thank you. I've got a hand from Elliot, if you can be really brief.
Yep. We had a PEB meeting here in Washington State, and we had 300 letters come in to our PEB organization. That's part of the Healthcare Authority in Washington State. And people testified for over 2 hours at how angry they were when their insurance might have been affected. So I've seen this firsthand. And many of them were Republicans. And the Republican legislators in our state were the ones that responded first positively, supporting us. So that blew me away, and it was an amazing experience. Thank you.
Thanks, Elliot. Well, we're so appreciative, Ross, Mary, and Rose, for you giving us your time today and your valuable insights, your knowledge, your background, and your advocacy to stimulate us to do more. And with that in mind, I'd like to remind our members that you might want to check out the weekly until the legislative session ends, legislative updates, 2 p.m. every Friday afternoon. So today's the day. Also, stay informed by reading the news flash every Friday, and you can join the legislative update calls on a monthly basis, also at 2 o'clock Friday afternoons when we're past session. Hopefully that will be soon. And I'll just a reminder that the meeting materials, presentations, and such will be emailed to everybody who's a registered attendee today. So thank you all for your time and your attention. And I think with that, we can be adjourned.
Thank you all.
Thank you all.